Week 4 is a really unique week in our clinicals because it's going to be formatted a little bit differently than what you're used to. The one half of the course is going to be focusing in on our CPR training. So, for those of you that are already CPR trained, you do still need to come to clinicals because it's going to be kind of enmeshed with the rest of our day. We're also going to be prepping ourselves for our midterm exam where we're going to be actually practicing the clinical skills that we're going to be assessed on. We're going to go over the breakdown of the points. You're going to feel really confident and comfortable on what next week's assessment is going to look and feel like. Last week's virtual training hit points on pathology and some of the things that you would commonly see in a patient's mouth. Here are some additional things that you would see on the routine in a patient's mouth. An abscess is a pocket of pus in a tooth caused by infection, which could be because of untreated cavities, injury, or old dental work. Some of the symptoms that a patient might have with an abscess is going to include pain, bad breath, a fever, and the abscess most likely would need to be drained. A root canal or antibiotics may be needed, and sometimes the tooth needs to be pulled. Untreated abscesses can come with severe possible complications, including loss of the tooth, blood infection, spread of infection to the soft tissue, the jawbone, and even other areas of the body that can cause issues with the brain, the heart, pneumonia, and other complications. The patient would be numbed and a lot of times preemptively given antibiotics to kind of start taking care of this infection. They would be lanced and drained. Now, I will forewarn you, there is a little bit of an odor when it comes to any sort of infection in the patient's mouth. Abscesses can also be a result of an impacted tooth. Your teeth actually start to pass through the gums, emerge during infancy, and this happens again when permanent teeth replace the primary deciduous baby teeth. And if a tooth doesn't come in or emerges only partially, then it's considered to be impacted. And this most commonly happens with our wisdom teeth, our third set of molars, and they're the last teeth to erupt, which is typically about age 17 to 21. An impacted tooth remains stuck in the gum tissue or bone for various reasons, and the area may be overcrowded, leaving no room for the teeth to emerge. For example, if the jaw is too small to fit the wisdom teeth. Teeth may also become twisted, tilted, or displaced as they try to emerge, resulting in impacted teeth. There may be no symptoms of a fully impacted tooth, or there may be symptoms to them, especially the partially impacted teeth, such as bad breath, difficulty opening the mouth, pain or tenderness of the gums or jawbone, prolonged headaches, redness and swelling of the gums around the area, swollen lymph nodes, a visible gap where the tooth did not emerge. And this video gives us a quick glimpse into the extraction of a third molar. The last pathology related video we're going to take a look at is a biopsy. If an oral examination reveals a lesion or abnormality in your mouth, your dentist might want to perform an oral biopsy. It's basically a surgical procedure where a small piece of that tissue is removed from the region so that a pathologist can determine the cause of it, whether it be cancerous or not. It may be in the bone or soft tissue of the mouth, and according to the dental surgeon, they'll remove a sample from those areas. In general, there's two types of biopsies, and they're going to choose whether it's an incisional biopsy, where they'll remove a piece of tissue from the lesion and another one from a healthy area around it, and then they're compared, or an excisional biopsy, where the surgeon removes the entire lesion, and these are generally performed on growths that are relatively small and in parts of the mouth that are easy to access. Apart from being a diagnostic tool, an excisional biopsy also prevents the growth from spreading further. This does carry a risk of infection, but there are extremely rare cases since we are using antibiotics. And on the whole, the diagnostic value of a biopsy is so much better and outweighs the risk.
We're going to go through a couple of different procedures that can be found on your Hammond Dental Care Platinum Plan sheet that breaks down the different dental procedures by their categories. Each of these categories are covered at a different percentage, and that is based on your insurance. So that's what we call a breakdown of benefits. Typically, you see things that fall under the diagnostic and preventative covered at 100%. Restorative, which are fillings, perio, and endo, a lot of times at 80%. Major work like inlays and onlays, crowns, removal of prosthodontics, surgery, implants, those types of things are major work and a lot of times covered at 50%. But that does vary on the insurance. So some insurances I've seen in the diagnostic section, and you have to pay like $5 for a cleaning, which to a patient doesn't seem like much, but in a large business where you have thousands of employees that go twice a year, that extra $5 that they're paying each visit is going to save you a lot of money. Your insurance has a couple of things. You have the breakdown of benefits, but you also have a maximum. The maximum is, think of it like your piggy bank. You can only use whatever is in your piggy bank, but you can't just use it on whatever you want. Insurance is kind of like a coupon. Like it's got certain percentages off certain procedures. It's either 100% off or it might be 80% off, but it's based off of your coverage that maybe you picked if you had options to pick. Now let's go through a treatment plan. The patient comes in and they are going to get an exam. Now this is a comprehensive exam. It's the first time they've ever been in the office before. So if we look at the ADA code 0150, this is a universal way of communicating, saying that they got an oral evaluation. It's comprehensive, meaning that we're looking at every single tooth in the mouth, looking for periodontal disease, evaluating what's missing, what's already present, all based off of that exam. Now the fee could either be a UCR, which is the usual customary rate, and that's what we charge everybody, or it may be an in-network fee. An in-network fee is if the insurance and the dentist have an agreement that the dentist will charge their customers less money, so their subscribers less money, it will save the insurance money, it will guarantee that the dentist gets patients, and then the patient ultimately wins out in the end too. In case they have to pay anything out of pocket, there's a discount. For our purposes, we're going to stick with the UCR. So if you have a sheet that says the member rate, go ahead and just scribble that out. We are only dealing with the UCR for our purposes. So if we look under the diagnostic and preventative section at the code 0150, the UCR is $78. Everything in this category is covered at 100%. So you could very easily just say in this column, we're going to estimate the insurance to pay $78. Now it does help us to understand where this number is coming from, and I'm not the biggest fan of math. I'm guessing you might not be either, but here's how it works. We take the fee of $78 and we times it by the percentage that it's covered at. So if we times it by 100%, it's multiplied by 1 and gives us 78. Then for the patient out of pocket, we take the fee of $78. We subtract the estimated coverage of $78 and it leaves us $0. Even though the patient's out of pocket is 0, that number, that money is coming from somewhere. It's coming from the maximum. So we have to take what's in the maximum currently, and this usually is reset every single calendar year, and we are subtracting every bit that the insurance pays. So they're going to take away the $78. This does not affect patient out of pocket. Currently, it is just subtracting the $78 from $1,500. So you should have $1,422 left over in your maximum. And this is for any dental procedure. So if you went to a periodontist, to an oral surgeon, and then to your general dentist, they're all pulling from the same funds other than orthodontics. A lot of times they have their own fund, their own ortho coverage if that's part of your plan. This patient also got a filling done that day. Let's say that they wanted some same-day treatment. Typically you'd see an exam, x-rays, and cleaning on that first appointment, but let's say they got an exam and they got a filling. So what we're going to do, tooth number 2, MO. So it's 2 surfaces because it's the mesial and it's the occlusal, and it's 2 surfaces on a posterior tooth because tooth number 2 is a posterior tooth. So if you look under the restorative section, for the code, we're going to do composite, so that's what resin is. Resin, 2 surface posterior is a 2392. That's what we're sending out to insurance saying, yeah, we did a 2392 on tooth number 2 on surfaces MO. The fee is $215. That's a lot of money. If you had no insurance, there would be no estimated insurance. All of the fees are your out-of-pocket. We're going to take our fee of $215. We're going to times it by the coverage. Now this is the restorative section, so the coverage is going to be different. It's going to be covered at 80%, so we're going to multiply it by 0.8. And so the estimated coverage is $172. Now we're on to the estimated patient out-of-pocket, which is the fee of $215 minus the $172, because the difference is what obviously is left over from what we charged and what insurance didn't pay. It's called co-insurance, and that's going to leave us with $43. But keep in mind, there's something called a deductible, typically anywhere from $50 to $100 per patient, usually with a family maximum of that. But this is done on the very first restorative or major work of the year, and it's only on that first procedure. It's not every procedure after that. So if you get a filling done on January 1st, you pay it, and you never pay that extra $50 the whole year. Or if you get a filling done on December 30th, you pay that $50, and then as soon as the new year rolls around, if you need a procedure done again, you have to pay it again. So really their out-of-pocket that they should expect to bring that day is $93. That $50 only affects the patient's out-of-pocket, so make sure not to subtract that from the maximum. You're going to take the $1,422 that was left, and you're going to subtract the $172. Because it's what the insurance is paying, not what the patient is paying that comes out of that amount. It is what the insurance pays. So that leaves us with $1,250. Last procedure we're going to treatment plan is going to be an extraction of number 5. If you were to look under your oral surgery section, and we'll say this insurance covers it at 50%. If it's an extraction of an erupted tooth, 7140, that's a simple extraction in our book, with a fee of $173, this is covered at 50%, so it's 173 multiplied by 0.5. So make sure you're typing that out and you're practicing along with this. That way you get an idea of how to do this math on your own, because you will have to do it on the exam. So it's $86.50. If I did the math and I subtracted the fee of 73, or I subtracted $86.50 rather from the fee, it would leave us with $86.50. It's that 50 right down the middle, so that's kind of easy to do. We're down at the maximum at $12.50, and this time we're taking the $86.50, but make sure you understand where it's coming from. Even though the numbers are the same, it's not always that case. So the numbers have to come from the insurance column. So when we subtract $86.50, it leaves us with $1,163.50. If we were to utilize all of this insurance in 1 year, it's called maxing out. And that's where it's beneficial to go to a network provider. So let's say if this maximum got all the way down to 0 and you needed a crown. If you were to look in the crowns and bridges section, instead of paying the UCR, you'd be paying that lesser member rate. So it benefits you because even though, yes, you're still paying a big chunk out of pocket, you get a discounted rate if you go to an in-network provider. Some insurances require this, where you have to go to an in-network provider, where you cannot pick and choose your providers. And there's some insurances where the premium is so little, so you're not paying a ton. Your options are very limited. Your coverage is very limited. And I've even seen some where they tell you what dentist you have to go to. So this gives you a good understanding of treatment plans and where the numbers are coming from, so you can better explain them to your patients.
The following training video is a composite procedure video designed to help the dental assistant to better understand the general steps of most composite filling procedures. This is not to take place of going to dental school or getting your training as an EFTA. It is simply to help you understand what typically occurs during a composite procedure appointment. Prior to the procedure being performed, the treatment would have been treatment plan documented in the chart. The treatment plan and cost would have gone over with the patient, and they would have accepted this treatment and cost and schedule. When you are looking at your schedule for the day, you'll confirm with their treatment plan that that's truly what needs to be done. From there, you're also going to be evaluating their medical history to see what type of anesthetic can you set up. For each patient, you're going to want to make sure that you have topical anesthetic, and you don't need a lot of it. Just a little goes a long way. And you're going to want to set up your syringe, your aspirating anesthetic syringe. Now, when determining what type of needle you're going to be using, this is going to be based off of the area of the mouth you're working on. So if you're working on an anterior or a maxillary tooth, typically your doctor is going to use a blue short needle. If you're working on a posterior mandibular, then typically they're going to be working with the yellow long needle so that they can perform a block injection. Purple needles are used particularly for pediatrics or really small mouths, but some doctors I've seen use only yellows, so it kind of is just a lot of times preference at that point. As you're assembling it, you're going to want to make sure that you take the hub end of the needle off first. This is what I like to stick my topical anesthetic into so that it doesn't get everything else sticky. So I like to stick that right in there and off to the side. Then you're going to take your anesthetic syringe and you're going to line up the needle with the threaded tip, screwing it on, making sure not to over tighten it, otherwise it becomes problematic and that threaded tip tends to come off with the needle. Next, what you're going to do is you're going to determine if the anesthetic that you have, the carpule, is the correct medication. If they are a heart patient, if they've had any adverse reactions, or they're pregnant, you're going to want to avoid an anesthetic that lists epinephrine as a ingredient. Check the expiration, make sure it's not expired, it's not broken, showing air bubbles or use, or any kind of discoloration, and no puncture marks on the top like this training one is. We're going to put in the rubber stopper in first by pulling back on the piston and the thumb ring, like so. You'll see the harpoon disappears down into it. We're going to place it in, line it up, and gently slide into place. Firmly grab that syringe and give it a nice firm spank at the end to engage the harpoon into the rubber stopper. And we're going to leave this capped for the doctor so that they can give the injections. When it's time to perform the procedure, the dental assistant may place topical anesthetic in the gum area close to where the injection will be needed. So on a maxillary tooth, they typically are doing what's called an infiltration injection. So the topical will be placed right near the apex of whatever tooth you're working on. If this were mandibular, I would place it near the tooth we're working on both the buccal and the lingual, but also back in the block injection area. And it'll take a couple minutes for it to soak in, to which the doctor's going to come in, give the local injection or the shot, and we'll start the procedure. In a composite filling procedure, especially on anterior teeth, it's extremely important that we get an accurate shade match. Last thing we'd want for our patients to do is walk out with a shade that looks nothing like their natural teeth. You'd want to make sure that you do this under natural light, so the operatory light will be turned away. preferably before drilling on the tooth and even before the anesthetic if possible. Once you find a shade that you like, then on each tab, there will be a shade that's listed, and that will coincide with all the composite materials that you're going to be using. During the prep part of the procedure, this is where the doctor will be utilizing their high-speed and slow-speed handpieces. You'll have your HV suction placed to make sure that all that tooth debris and aerosol are getting caught by that. And then we're going to isolate the tooth. Cotton rolls, 2x2s, dry angles, all these cottons are used in basically every procedure, so these are a given that they're going to be out and ready to be used. After the tooth is isolated, the steps are very similar to that of a sealant, which you'll start off by passing over the syringe of the etch to the doctor underneath the patient's chin in the position of use so they can grab and go. I'm going to syringe this on all the prepared surfaces. We call this a prepped tooth. And that's going to sit there for about 30 seconds, to which you then are going to rinse and suction it away. When this 30 seconds is occurring, you can already have your HV and your air water syringe ready because you know that that's going to be there. You should be anticipating your needs. And the more that you work with the doctor, the easier this becomes. Tooth is thoroughly dry because this is a chemically bonded system, so we don't want any moisture being introduced, whether it's through saliva or through the air water syringe. Next, what we're going to be getting is the bond. So what the bond essentially acts like is a super glue. It's the adhesive layer between the tooth and the composite filling. This we don't want to put out ahead of time because if we do, then what happens is that bond, being a light cured material, will end up hardening in the DAPN dish just like this, and then it's not usable. We're going to recap our bond. Now this is a communal tub, so just make sure that this gets wiped at the end of the procedure. You're gonna grab your DAPN dish, your micro brush, and if it bends, so if it has a little perforation, go ahead and bend that. And you're gonna hand this to the doctor underneath the patient's chin, ready to go, pre-dipped, and they're gonna grab it. I always like to keep my DAPN dish just below the patient's chin throughout this whole step so that when or if they need to re-dip the bond, then they can. They're going to apply this to the prepared surfaces. There are primer adhesives where they're a liquid etch and a liquid bond. There's a 2-in-1 system. There's also the, like we have, the acid etch and then the liquid bond. Now, if we apply the liquid bond, typically what they're going to want to do is do a quick little air dry just to ensure that there is no puddles, essentially, of the bond, so no thick layers of it. What I like to do is take my air water syringe tip off to the side and test that it's air first before I do this and end up spraying it with water. 3-second air dry there, so your little hair dryer. You're going to make sure that this curing light is set for 10 seconds, and we're going to cure the bond for 10 seconds. Now I'm thinking ahead, the next step, the doctor is going to want to start applying the composite, but because this particular filling on an anterior tooth happens to be involving the interproximal, so the distal, they're going to want what's called a matrix system, something that's going to go between these two teeth, separating them so that when I place my filling, it doesn't stick to tooth number 7 and end up creating one large tooth. So for the anterior teeth, the matrix system of choice is typically your clear mylar strip. It's just a thin piece of clear plastic that essentially you floss in between the teeth and create a wall between tooth numbers 7 and 8. They can go through with a wooden wedge. This is going to go through the lingual embrasure, so it goes through the tongue side of the tooth and helps to wedge that into place. Doesn't work the greatest on these fake teeth, but definitely does on real teeth. The composite gun, you're already gonna have preloaded with your composite, so to take it in and out, it pops in and out very easily in most cases. You would have already selected the correct shades, so you can find the shades on the caps themselves. So this is an A2. This is a one patient use product, so there would be a cap on here you take off prior to handing it to your doctor. Again, under the chin in the position used so they can grab and go. Thinking the next step ahead, they're gonna want some kind of composite placement instrument. There are lots of different instruments that are out there available. The two that we have in our kit setup, we call it our gold composite instrument and our plastic composite instrument, which these we have a couple different colors and different sets, so they might be black or white or clear, but just know that the gold has the gold color and the plastic has the plastic look. There are multiple instruments with different purposes in their design, but it is just preference as to what your doctor prefers to use, which you'll then know and anticipate that. They're gonna squeeze the composite gun to get the composite to start extruding out. And this is a really thick plastic, almost like a paste. And so it can be kind of tricky to get it to stick to the tooth, especially when we're working with these fake plastic teeth. You'll notice that it's a little harder to work on these than a live patient. You know, their tooth might be loose in the socket or this might pop out. So try not to get too frustrated when it comes to the fake teeth. As the doctor is using the placement instrument, a little trick of the trade, it's gonna make you look a lot more polished, is you're always gonna wanna make sure that you have a piece of 2x2 gauze just below the patient's chin. So as they're working, they can stick their instrument out and you will wipe it clean as they go. When they're happy with the shape or they're ready to cure that layer of composite, we are then gonna set it for 20 seconds and cure all the surfaces as needed. There are lots of techniques as to placing the composites. You know, it is an art, just like with any other type of art, there's lots of techniques to it. So there is a flowable composite that comes in different shades, like this is an A3. This is just a much thinner material than that paste that we were using, so it's great in really small cracks and crevices. You extrude it out just like you would your sealant material, so you squeeze and it comes out really runny. It also helps to fill in any kind of gaps. So if there's a small gap between the filling that you put in and the tooth itself, then they can go through and squeeze and syringe it in there to help create more of a seamless look to it. Let me see, this is not a very pretty filling we have right now. Different settings for different products. So this one's on like a pulsating setting on the curing light. Other ones are a constant light. Make sure that you know what your product requires. They're always going to want to check the bite, and especially if it's an interproximal, they're going to want to use floss to check in between. But the articulating paper goes into your Miller forceps by squeezing and opening, placing it in like a flag, and having them chomp chomp, slide side to side, to then evaluate should these be adjusted. If they need adjusted, then we can use different burrs like the finishing burr set. Each of these have different names and functions, but collectively, this is a finishing burr set. When they're done, the patient is ready to walk out the door, smile, use that tooth to eat because it is completely set up and there are no restrictions in regards to that. Now there are restrictions because they're numb. They're definitely not going to want to eat anything that's hot temperature wise, or maybe they wouldn't know how hot it was. Usually just if the numbing wears off, that's the best time to then go ahead and eat and drink. But it's not going to make it fall out. It's not going to make it, more sensitive, but there can be some sensitivity. Anytime that we work on your teeth, there is that slight chance there can be some sensitivity. So make sure to educate your patient that we just worked on your tooth. It's normal for a couple of days that it might be a little sensitive. Now, if it persists or it's unbearable, give us a call, and it's a possibility that maybe that bite's off because sometimes the bite registration paper doesn't pick up what needs to be fixed. And this should help you to get a better understanding of the general step-by-steps of a composite procedure.
Dental impressions can be taken for a number of reasons and with a number of different materials like alginate or polyvinyl materials. One way that impressions can be taken, and it's a much more comfortable experience for the patient, is by using a scanning device. This isn't really even an impression anymore. It is a digital scan using a really high-tech piece of equipment that allows us to create a 3D rendering of the mouth to create different things like crowns, dentures, and even our clear aligners that you're going to see like Invisalign and ClearCorrect. Impressions are a vital part of crown and bridge appointments, and the materials that you'll see used for those procedures are going to be different than the one that we're going to take on each other in class. Prior to taking really any impression, but specifically with a full arch impression, you're going to make sure that you're going to try these trays in. Now, we're going to use plastic perforated trays. There's metal trays, non-perforated trays, and every office kind of has their own reasoning as to why they like to use one or for the other. Try in those trays to make sure that they are the proper size and fit. They don't need to be too small because we don't want to hit the sides of the teeth, and we don't want them too large where they would be uncomfortable for our patient to wear. Now, we are actually going to be taking these impressions to make whitening trays. And so what we want to make sure that we're doing is following the proper mixing ratio for the product that we're using. We're going to start with our alginate powder. We've already tried in our trays. We're going to pre-scoop our powders, and we're going to follow the instructions. And in this case, it's going to be 2 to 2, 3 to 3, depending on what arch that you're working on. And if you're ever unsure of the mixing ratios, you can just simply look at the container of the material. Now that we have our powder in our mixing bowl, we are then going to get our water. Now, the water itself, if you use cold water, it's going to slow down that chemical reaction and give you more mixing time. But if you use warm water, it's going to speed it up, which that is beneficial for our patients that we know it's going to be a lot more uncomfortable for them. When we're getting this ratio, when we're measuring it, if it's a 1-to-1 ratio, it's not one vial to one scoop, it's one line to one scoop, and then 2 lines to 2 scoops, and 3 lines to 3 scoops. Pour the water directly into your alginate and begin to mix. I like to always just do a little bit of a stir at first to incorporate that water so it doesn't puff everywhere, because this can get pretty messy. And then we're going to use a spatulating motion where you're going to quickly mesh this material together up against the sides of the bowl. We should be able to mix this in about a minute or less, especially for using fast set material. It's going to set up on you pretty fast. So mix it so it's nice and smooth. There aren't any lumps and clumps into it. When we're working on the mandibular arch, you're going to load one side of the tray at a time, scooping out your alginate, making sure it's nice and smooth across it. A little trick to make that even nicer is once it's all in the tray, you can get a little bit of water on the fingertips of your glove and gently gloss it over the top of that alginate, and it's going to make a nice smooth surface. Now that it's loaded, you're going to go over to your patient and place it into the mandibular arch, making sure that their tongue is lifted up. You center it and press from the back to the front so that the excess material is pushed towards the front of the mouth. You're also going to want to make sure that you are keeping constant pressure so that the patient isn't shifting this with their tongue, that their lip is pulled out of the impression, and that if the patient is feeling uncomfortable, like they're going to gag, they can lean forward. That way it doesn't feel like it's going towards the back of the throat. The mandibular doesn't typically tend to be as uncomfortable as the maxillary. When you go to remove it, you might have to pop loose the suction. Don't panic. It's not stuck in there. Just pull up from the gum line and evaluate your impression to make sure that all the teeth are present. You didn't hit the tray. It's nice and centered. That way you can take it back to the lab. If you're not going to immediately pour it up, wrap it in a damp paper towel and place it into a lab bin with the patient's name. Now we're going to mix up our maxillary impression. Again, centering it, pressing from the back to the front, making sure that the lip is out and over top of the impression. Continually keep this in place until it's time to pop it loose. After you've gotten both of your impressions, now it's time to move into the lab. And honestly, I think this is a lot of fun. It's very artsy. And there are specific measurements, so many grams to so many milliliters of water of this stone material. And stone is a plaster material. We get it from gypsum. It's a mineral that we mine from the earth. But we really just kind of eyeball it for the mix that we want. We're going to get a Dixie cup full of stone and slowly add water in. The nice thing is if you do add a little bit too much water, you can add more powder to it. If you don't add enough water, so it's really dry, you can add more water to it. The consistency that I personally like to go for is more of like a frosting consistency. Some people like there's a little bit thinner. Some people like there's a little bit thicker. The main point is at the end, we should have a bubble-free product. There shouldn't be air voids in that final 3D rendering of the patient's mouth. You want to place your disinfected, so you're going to spray it with a disinfectant, impression onto what we call the vibrator. It's a machine that's going to vibrate that material and slowly, little by little, add that stone material into one area of the alginate impression, tipping and turning it and allowing it to flow through those teeth. Vibrate all of the liquid out, all the air bubbles out. Once you've vibrated that completely out, then you can start adding more of that stone material to the top. Now this assistant here likes their material thinner than I personally like to. It is a preference thing. So as long as that final product is void free, you have a nice thick base, then it doesn't really matter if it's a little thinner or a little bit thicker. The reason I don't like it so thin is because when I do invert it for what we call the inverted technique, it tends to kind of slop out of the sides of the base plate. There are different products. This is a lab stone. It's a buff stone, rather. There are different ones that set up quicker. They're maybe more dense. If you're in an ortho office, you might be using what's called plaster. It's made from the same gypsum, but it's a lot finer. It's got that pretty white look to it. The crystals in it are going to form more uniformly, and that way it's prettier, it's smoother, but it's a lot softer. So you would drop a plaster model and it basically would break apart into pieces, whereas a stone model, you'll drop it, and most of the time it's just going to bounce onto the floor. Now we're going to take our excess material and we're going to put it onto our base plate. I like to put a little doggy pile right in the center of that base plate there. You may not have a lot extra. This is going to be something that you're going to have to practice and get better at as you go.
We're going to start by wearing the proper PPEs, which would be eyewear protection. We're going to remove the alginate impression from the stone model. Usually this peels off rather easily, but if it doesn't, you can use a lab knife, place it underneath the impression, twist like a key, and pop it off. If you are pulling off this impression as soon as it is set, you will not have to pick off the alginate and it be hard as you see in the video. It would normally be still a really soft and pliable material. This is the model that has sat for a little too long. You don't want to let it sit for too long because when you're pulling this off, you risk breaking the teeth. But we see that there are no broken teeth, no air bubbles, so we're going to clear off our model trimmers. We're going to rest it flat on the platform and we're going to reach back and turn on the water and the trimmer, which are typically located towards the back of the trimmer itself. We want to make sure that the water's on but not too high where it's spraying all over the place. You'll notice if you don't have enough water, your trimmer itself will end up turning kind of a yellowish color using the stone. Keeping the model flat on the platform, we're going to press it against pressing with force against the rotating wheel. And we're going to start trimming off the most posterior region of this model. This model has a lot of overhang on it that we want to reduce, whether it be for study cast to go over treatment with a patient or to fabricate inside a lab. It's just going to be in the way. So we're going to keep pressing as we're going. You'll notice it starts to become really flat on the edges. Make sure you're never holding it up off the platform or it starts to kind of jump around on you. But we're going to go around the edges, refining that, making it more aesthetically pleasing and a little bit easier to fabricate onto. So we're keeping it flat on the platform, constant pressure, making sure our fingers are clear of the spinning wheel. We're also going to be careful that we don't trim too close to the teeth themselves, but you'll notice that it's looking a lot better. You can see the anatomy, you can see the vestibular area, so we're going to continue through removing the excess material. You'll notice that pieces of the stone do fly, so eye protection is a must. A lot of trimmers do come with shields, these plastic protective covers essentially that go over top of the platform that would help prevent that stuff from flinging up toward your face. There's still a good amount of overhang left around this, so sometimes it might be thin enough we can just pop off, but it's not. So we're going to go through and finish up cleaning this up. So I just keep a nice smooth rounding motion as I go. Be careful not to press your model too far against the trimmer, because then what ends up happening is you start to trim away portions of the teeth. As you can see, these buccal portions have been trimmed away. And when we're fabricating things, it doesn't work for what we want. The last trim that we're going to do, we're going to make sure our fingers are away from the trimmer. We're going to keep that flat portion that we trimmed first, flatten the platform, and we're going to press against the wheel. What we're doing is we're reducing the height of this platform, which in a lot of lab cases, you don't need to do this. So if we're mounting them for a denture case or anything like that, this wouldn't be needed. But since we're going to be fabricating whitening trays from this model, we actually want to create a little air gap. We want to make sure that when we're vacuum forming the material to the model, it's able to suction the air from the lingual surfaces. So that's what we're doing now. This may take you a while if you have a really thick base, but eventually you'll end up getting a hole in the palate or the lingual portions. When you're done, make sure that you shut off your trimmer. Anytime you walk away from it, it needs to be shut off, and shut off your water to prevent flooding the area. We're going to take off the platform and clean it. This is part of the routine maintenance, that when you're done with your trimmer, you should remove your platform. Now our sink has a special trap underneath it to prevent that stone from building up in the city plumbing, but we still want to get any chunks out of the sink to make sure it stays clean. You'll notice that there are still chunks in the trimmer itself, so we're going to just rinse it down with just some regular sink water. Replace our cleaned platform. And you're all set.
To fabricate the whitening trays, now we'll take our whitening tray material, which is a really soft, pliable material that usually has a protective film so it doesn't become discolorated and stick to the other material in shipping. Peel out that outer film and place it into your suck down machine. Latch that suck down machine into place. Raise up the frame and tighten it with the two black knobs on the back, and place your model teeth side up in the center of the perforated platform. Here's a different view of that. After that material has heated and is soft and pliable, you'll drop the frame down to the mouth, and you'll flip the switch to the right to suck it down. And that's going to be about 10 seconds that it's going to suck down. After you remove it from the frame, be careful not to pull on and distort the tray itself. You're going to want to wait about 10 minutes or so before you pop it out, otherwise it'll stretch and distort. Once it's cooled, you can pop it out of the model, give the patient their model, so if they ever need to have their whitening trays remade, they don't have to redo the whole impression and model, and it saves them some time, money, and honestly just being comfortable. Unlike retainers or mouth guards, you can easily just cut this with a pair of tissue scissors. You'll go around the excess just to get it out of your way. Cut along the lingual surfaces of the tooth. Then lastly, scallop around the edges of the buccals and facials. We have two finished products. The one here does not have blockout, but the one with the blue has blockout, which is an added material that you can put onto the model that creates like a pocket for the whitening gel to sit into, which is not necessary, but some offices like to do that for their patients. You'll then send your patient home with a set of whitening gel that they'll place a small pin drop into the fronts of the teeth that they want to whiten. There are other options like pre-filled whitening trays, in-office Zoom whitening that utilizes a bright light that's going to work with a gel that's applied directly to the teeth. Usually you have to use like this special retraction material that goes around the gums to create a brighter, wider smile. The topics that we're going to cover today in our virtual training are vital signs and why and when they are important to take, risk management and how that's actually going to protect the practice and protect your job. We're going to do a CPR preview where it's going to explain those clinical skills and kind of the science behind different things that we might experience in a medical emergency. But keep in mind that just because you're going through that, it is a preview. It is not to certify you in CPR. So at the completion of the virtual training, you still need to complete the hands-on portion. It will certify you in CPR for 2 years. It is required for you to have if you're going to get your dental and maintain your dental radiographer's license. We'll also talk about some emergency protocols and some steps that your office might take in some different emergencies. Now, obviously, I hope that you never have to utilize these protocols, but they are things that usually an office has in place and is something that you should be trained on. If your office doesn't go over your emergency protocols upon hire, I highly suggest you just taking a moment to ask them, what do we do in these specific scenarios? So in the off chance that they do occur, you feel really well prepared and there's no questions, and it kind of minimizes the chaos when something like that goes awry. Vital signs are about 4 to 6 crucial signs that indicate the status of vital functions. These measurements are taken to help us know whether or not a patient is in general health, or also helps us give clues to possible diseases or even medical emergencies that might occur. Vital signs can be different because of a number of factors. It can vary from age, gender, medication, the results of the environment. Maybe someone is really stressed out or they're really anxious about being in the dental chair. How do you think that might affect their vitals? Do you think they're going to be like totally level when it comes to their blood pressure and their pulse? No, we should expect those to be slightly elevated. Now, if they're in a dangerously elevated level, that's then we have to decide whether or not we should be completing dental treatment that day. Physically, maybe they just exercised or smoked. I mean, if they just ran 5 miles and they came straight in the door, that pulse, that respiration, those different vital signs are also going to be elevated, and maybe for like a air quotation healthier reason than say if somebody was anxious, those are going to both affect those vital signs and raise them. It is good practice to take vitals at every visit. Now, there are some vital signs we'll talk about that you maybe won't take or record, but they are ones that you should be mindful of because they could be indicators of other health conditions or even possible medical emergencies that might occur. The normal oral temperature for a person is 98.6 degrees Fahrenheit. If it were to be elevated, what would that be a sign of? Did you know that your body raises its own temperature in the presence of infection? It tries its best to eliminate the invader using a really high temperature. And in some cases, it's actually best to let it run its course. When we're taking fever reducers, it's reducing your body's natural reaction and abilities to fight off that infection. It also, when you take fever reducers, makes the symptoms go away. So it's a lot more comfortable. You can rest. So there are definitely pros and cons to this medication where you'll see, a lot of people want to take it just before bed so that they have a chance to rest. But they allow their fever to run its course without it becoming dangerously high before they use that medication to step in and reduce it. There are other ways that someone can reduce their fever without having to take a medication. They can sit in a warm bath or warm shower, not a cold, not a hot. They can use compresses. Those would all be ways that they can naturally lower that temperature without it being dangerous. We, as a dental practice, should not be treating patients who are running a fever because that could mean that they have something that could be infectious. And as a precaution, we don't want to get sick. We don't want to get the other patients sick. It's best just to reschedule our patients until they've been 24 hours without a fever. That's the best rule of thumb. 24 hours, fever-free. Then we can feel pretty confident that that's not something that we can potentially get sick from. Your office may still be employing taking actual forehead scans of patients and then recording it in the patient's chart. A lot of offices have stopped doing that post-COVID and simply allowing the patient to then self-monitor and let us know whether or not they're feeling well. We don't want a patient coming in if they're feeling under the weather, even if they're not running a temperature. Sometimes it is best, even though it leaves a hole in our schedule, to just reschedule them. The Wikipedia definition of respiration is in physiology, respiration is the movement of oxygen from the outside environment to the cells within tissues and the removal of carbon dioxide in the opposite direction to the environment. It's breathing. The normal respiration range for an adult is 10 to 20 breaths per minute. Now, if I sat here and told you I'm going to count how many times you breathe, do you think that you might alter your breathing pattern, maybe even subconsciously? The same thing with the patients. And usually we're not writing down respiration rate unless we're in like a general anesthesia or a oral surgery setting. But if they're sitting down and we notice that they're breathing way too slow or not at all, or they're breathing way too quickly and hyperventilating. Those would be reasons that we're kind of monitoring and noticing that respiration rate and realizing it might be something that we want to address. Because obviously if they're hyperventilating, they could pass out on us, or if they're breathing really shallowly, we could have a medical emergency on our hand. Take your 2 fingers, press them on the outer part of your neck. Can you find that carotid artery? What about on your wrist, just below the thumb? Can you find the radial artery? And lastly, on the bend of your elbow, 2 fingers, can you feel the brachial artery? There's plenty more arteries throughout the body, but those are the 3 big ones that we look for the pulse. The pulse represents the tactile arterial palpation of the cardiac cycle. What does that mean? It's how many times your heart beats. The pulse may be palpated or felt any place that allows an artery to be compressed, but those 3 that we went over are going to be probably the 3 easiest. The average adult is 60 to 100 beats per minute, with infants and children being slightly elevated above that. And what we're looking for is not only the rate, but also the rhythm. We want that constant metronome beat of bam, 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 and not skipping or beating too quickly. We want to feel that it's clearly distinguishable and not too faint, but also not too strong. We've all felt our heart racing. Something scared us. It elevated our heart rate because of the adrenaline rush that our body experienced. And we probably even instinctively put our fingers on the carotid artery there on our neck and felt to see what our pulse was. Maybe not actually monitoring and counting it, but we were trying to see if it felt normal. When we're calculating the rate, to sit there and count for a full minute can kind of be a little bit tedious. So what you could do is you could count the beat for 15 seconds and multiply that number by 4, or the beat for 30 seconds and multiply that number by 2. So there's a little bit of math, but hopefully it's not too hard for you. Also related to the heart, other than just the pulse, is the blood pressure. The blood pressure is how hard is your heart having to work while pumping blood through the circulatory system. We want to take this each visit along with the pulse, and a lot of times the auto monitors that just strap around the wrist like a little bracelet will give you both the pulse, the blood pressure, and even sometimes the pulse oximetry. You can get an easy little clip-on that goes on the fingertip, and the pulse oximetry is going to be measuring how much oxygen concentration is in the blood. Prior to any dental procedure, we're going to want to make sure that we get the vital signs of our patient. This is going to be your extractions and your recall appointments alike. This is going to help us to help monitor our patient's health, but also to help us predetermine whether or not there's a risk for any kind of medical emergency occurring while the patient is in our care. There's a couple techniques. One of the more common, easier way is for the use of an auto blood pressure cuff, but in some cases it doesn't fit or it doesn't give us an accurate enough reading, and that's where having the skill set to perform a manual blood pressure reading is really helpful. You'll want to make sure that you select the correct size cuff for your patient and place it on just above, about 2 fingers above the brachial artery. That's the artery that you're going to find right there at the bend of the patient's elbow. You'll want to make sure that the patient's legs are uncrossed and that they didn't just smoke or do any kind of strenuous exercising, because that can also affect our readings. Another thing is to make sure that you're putting that blood pressure cuff on either a preferred arm or the arm that's medically necessary. So if they have a mastectomy or an AV shunt, you are going to want to use the opposite arm to that. Once it's placed into place, you'll put the top of your stethoscope right above that brachial artery, being sure not to use your thumb so you don't accidentally hear your own heartbeat here, pumping up the air bulb so that the sphygmomanometer, basically that tire pressure gauge, starts to go up. The average adult blood pressure reading is 120/80. That first number is going to be your systolic number. The systolic number is going to be the top of the fraction, and the diastolic number is going to be the bottom number of the fraction. So 120/80 is average. I like to ask my patients what theirs is normally because when you're pumping up that blood pressure cuff, what you're actually going to want to make sure that you're doing is making sure that you're going about 20 to 30 marks above the systolic number that they've given you. So say they typically run 120, pump it up to 140. And as you slowly release the metal valve that's on that bulb, you should be listening for a sharp, basically drum tap is what you're going to hear. Notate what number that hand is on, and that's going to be your systolic reading. And you're going to continually slowly releasing the air and pressure of the cuff until you hear that sound dissipate. Notate when that sound dissipates because that's going to then be your diastolic number. If the blood pressure number is too high and they're pre-hypertension or hypertensive, then it may be a contraindication to treatment today, especially for doing a dental surgical procedure. After you've gotten your blood pressure reading, then you can tell your patient what their blood pressure was and then put the notations into the patient's chart.
The last thing that your dentist is going to want to deal with is a lawsuit, whether it be malpractice or a patient felt wrong because of their bill. There are a lot of systematic steps that we can take as the employees to make sure that we are not at risk of a lawsuit. We call this risk management. In risk management, the idea is that the patient record is a permanent and legal document. It can be used as evidence in a legal lawsuit, reference for a forensics case, and even as reference for insurance companies. So these records are generally kept in an electronic form with a backup saved either on an external hard drive or an offsite server to protect the patient's information from being lost due to theft or natural disasters. Some of the forms that we're collecting are their information form with their name, address, and insurance information, their health history, including their medication list and current dental health, them signing their HIPAA consent and listing any emergency contacts that could have access to their medical records. Their social security number is being collected and used for typically insurance. A lot of them will use that as their member ID. That's how we send in their insurance claims and get payment on their behalf. We want to make sure that we're taking special care to keep all their PHI, protected health information, protected and private, following those HIPAA laws, making sure that when we're sitting at the front desk and making phone calls and speaking to the patients that are up there, that we want to use a lower tone. Maybe if there's other patients around, like if I'm going over a treatment plan, I don't say what they need done and how much it's going to cost because that's already been gone over in the clinical. I'll point at the sheet. This is what they want to do. This is how much it's going to cost. Do you have any questions? And that's a great way to kind of adhere to that privacy law. But if you need to speak, just use a lower tone, trying to be mindful of what's around you. If you are documenting in a, say, paper chart, then you're going to document everything thoroughly in pen. We don't erase, white out, delete, correct a mistake, unless we're correcting it properly with a single strike through the mistake and our initial next to it. We want to make sure that we update their records every visit, especially that medical history, because that information is going to constantly change. And as it changes and we update it, it can help us to hopefully prevent preventable medical emergencies. The progress notes are documents that are taken at the completion of each procedure and should include information about the patient's vital signs, their scheduled treatment, the procedures that were actually performed with the tooth number and surfaces, the type and amount of anesthesia, the dental materials that we've used, how the patient tolerated the procedure, the post-operative instructions, and all of these should be clear and concise and recorded accurately. Anytime that you do a keystroke within a digital record, that is recorded within the software. So any kind of changes is going to automatically be recorded by who made the changes and when. It is good practice to have informed consent and refusal forms signed and in the patient's chart in the off chance that they may try to file for a legal action against your practice. A patient's clinical chart is going to actually be the most detailed document, notating the clinical findings of existing restorations, missing teeth, periodontal conditions, and treatment that we have planned for the patient. Treatment planning should be thorough and something that even the clinical assistant's able to do, able to explain to the patients what procedures we're wanting to do, what the costs are associated with it. And as you become more experienced and comfortable with working with your dentist, you're going to know what length of time your dentist is going to need for certain procedures. So if they're doing a filling with a certain amount of surfaces on a front or a back tooth, it may take them a certain amount of time that then you can relay to your front desk and have them schedule it accurately. When a patient becomes established in your office, we will not only look at the restorations that are already there, but determine whether or not the patient is in need of any treatment. Each time that the patient comes in, the doctor is going to perform an exam to make sure that there is or is not something that needs to be addressed. And this is where treatment planning comes into play. This is not just something that the front desk does. In a lot of offices, the clinical assistant does go over treatment with the patient on what needs to be done, how the procedure is ran, and sometimes even the cost and how their insurance benefits might work in these particular scenarios. And while you may not be interested in being a front office staff member, there are times that you want to be cross-trained so you have a better understanding of what's happening with your patient's care. We do have some papers in our workbook that go along with this next section. So once you jump onto that video, then you can pause, flip open to those pages, and follow along with it because there is a little bit of math. Don't worry, the beauty of it is it's going to be simple, and majority of the time your computer handles it for you anyways. But when we do it by hand, it's going to make better sense as to what's really happening here. Upon selection of your patient in the Open Dental software, you can go to their clinical chart by clicking on the tooth icon on the left. This is where you're going to see a visual representation of things that have been completed by us in blue, completed by other providers in green, so they came in and this was already done, and treatment that we are recommending them to have done in red. So you've got fillings and extractions, and you'll notice that their extractions here are using an X icon, whereas we've been using circles and lines. Nobody's doing it wrong in this situation. It's just this is how the software was set up. How you would input the treatment is you would click on the tooth that you want the treatment applied to, and it will highlight its number. And then you'll go to the right side and you'll see quick buttons where it's got some commonly used procedures, or you can click on the procedure list button. That's going to pull up the whole list of ADA codes that break down into different categories what procedure you want that tooth to have done on it. After you click it, it's going to automatically put it onto there. It's also going to put it in the default view description progress note area of the chart. This is actually where you will put a patient's progress notes. You'll right-click the procedure you did that day that's listed there on the screen, and there'll be a section to add notes. You can set up what are called quick notes, where it'll ask you questions like what was the tooth number, what were the tooth surfaces, and you check boxes, and then it auto-populates your progress notes for you, and then you can change and customize it once it's done if you need to. You also have a quick view of the patient's medical history here, medications, significant health history, things like allergies are going to be listed in that patient information section.
We're going to go through a couple of different procedures that can be found on your Hammond Dental Care Platinum Plan sheet that breaks down the different dental procedures by their categories. Each of these categories are covered at a different percentage, and that is based on your insurance. So that's what we call a breakdown of benefits. Typically, you see things that fall under the diagnostic and preventative covered at 100%. Restorative, which are fillings, perio, and endo, a lot of times at 80%. Major work like inlays and onlays, crowns, removal of prosthodontics, surgery, implants, those types of things are major work and a lot of times covered at 50%. But that does vary on the insurance. So some insurances I've seen in the diagnostic section, and you have to pay like $5 for a cleaning, which to a patient doesn't seem like much, but in a large business where you have thousands of employees that go twice a year, that extra $5 that they're paying each visit is going to save you a lot of money. Your insurance has a couple of things. You have the breakdown of benefits, but you also have a maximum. The maximum is, think of it like your piggy bank. You can only use whatever is in your piggy bank, but you can't just use it on whatever you want. Insurance is kind of like a coupon, like it's got certain percentages off certain procedures. It's either 100% off or it might be 80% off, but it's based off of your coverage that maybe you picked if you had options to pick. Now let's go through a treatment plan. The patient comes in and they are going to get an exam. Now this is a comprehensive exam. It's the first time they've ever been in the office before. So if we look at the ADA code 0150, this is a universal way of communicating, saying that they got an oral evaluation. It's comprehensive, meaning that we're looking at every single tooth in the mouth, looking for periodontal disease, evaluating what's missing, what's already present, all based off of that exam. Now the fee could either be a UCR, which is the usual customary rate, and that's what we charge everybody, or it may be an in-network fee. An in-network fee is if the insurance and the dentist have an agreement that the dentist will charge their customers less money, so their subscribers less money, it will save the insurance money, it will guarantee that the dentist gets patients, and then the patient ultimately wins out in the end too. In case they have to pay anything out of pocket, there's a discount. For our purposes, we're going to stick with the UCR. So if you have a sheet that says the member rate, go ahead and just scribble that out. We are only dealing with the UCR for our purposes. So if we look under the diagnostic and preventative section at the code 0150, the UCR is $78. Everything in this category is covered at 100%. So you could very easily just say in this column, we're going to estimate the insurance to pay $78. Now it does help us to understand where this number is coming from, and I'm not the biggest fan of math. I'm guessing you might not be either, but here's how it works. We take the fee of $78 and we times it by the percentage that it's covered at. So if we times it by 100%, it's multiplied by 1 and gives us 78. Then for the patient out of pocket, we take the fee of $78. We subtract the estimated coverage of $78 and it leaves us $0. Even though the patient's out of pocket is 0, that number, that money is coming from somewhere. It's coming from the maximum. So we have to take what's in the maximum currently, and this usually is reset every single calendar year, and we are subtracting every bit that the insurance pays. So they're going to take away the $78. This does not affect patient out of pocket. Currently, it is just subtracting the $78 from $1,500. So you should have $1,422 left over in your maximum. And this is for any dental procedure. So if you went to a periodontist, to an oral surgeon, and then to your general dentist, they're all pulling from the same funds other than orthodontics. A lot of times they have their own fund, their own ortho coverage if that's part of your plan. This patient also got a filling done that day. Let's say that they wanted some same-day treatment. Typically you'd see an exam, x-rays, and cleaning on that first appointment, but let's say they got an exam and they got a filling. So what we're going to do, tooth number 2, MO. So it's 2 surfaces because it's the mesial and it's the occlusal, and it's 2 surfaces on a posterior tooth because tooth number 2 is a posterior tooth. So if you look under the restorative section, for the code, we're going to do composite, so that's what resin is. Resin, 2 surface posterior is a 2392. That's what we're sending out to insurance saying, yeah, we did a 2392 on tooth number 2 on surfaces MO. The fee is $215. That's a lot of money. If you had no insurance, there would be no estimated insurance. All of the fees are your out of pocket. We're going to take our fee of $215. We're going to times it by the coverage. Now this is the restorative section, so the coverage is going to be different. It's going to be covered at 80%, so we're going to multiply it by 0.8. And so the estimated coverage is $172. Now we're on to the estimated patient out of pocket, which is the fee of $215 minus the $172, because the difference is what obviously is left over from what we charged and what insurance didn't pay. It's called co-insurance, and that's going to leave us with $43. But keep in mind, there's something called a deductible, typically anywhere from $50 to $100 per patient, usually with a family maximum of that. But this is done on the very first restorative or major work of the year, and it's only on that first procedure. It's not every procedure after that. So if you get a filling done on January 1st, you pay it and you never pay that extra $50 the whole year. Or if you get a filling done on December 30th, you pay that $50, and then as soon as the new year rolls around, if you need a procedure done again, you have to pay it again. So really their out-of-pocket that they should expect to bring that day is $93. That $50 only affects the patient's out-of-pocket, so make sure not to subtract that from the maximum. you're going to take the $1,422 that was left, and you're going to subtract the $172. Because it's what the insurance is paying, not what the patient is paying that comes out of that amount. It is what the insurance pays. So that leaves us with $1,250. Last procedure we're going to treatment plan is going to be an extraction of number 5. If you were to look under your oral surgery section, and we'll say this insurance covers it at 50%. If it's an extraction of an erupted tooth, 7140, that's a simple extraction in our book, with a fee of $173, this is covered at 50%. So it's 173 multiplied by 0.5. So make sure you're typing that out and you're practicing along with this. That way you get an idea of how to do this math on your own, because you will have to do it on the exam. So it's $86.50. If I did the math and I subtracted the fee of 73, or I subtracted $86.50 rather from the fee, it would leave us with $86.50. It's that 50 right down the middle. So that's kind of easy to do. We're down at the maximum at $1,250, and this time we're taking the $86.50, but make sure you understand where it's coming from. Even though the numbers are the same, it's not always that case. So the numbers have to come from the insurance column. So when we subtract $86.50, it leaves us with $1,163.50. If we were to utilize all of this insurance in 1 year, it's called maxing out. And that's where it's beneficial to go to an in-network provider. So let's say if this maximum got all the way down to 0 and you needed a crown. If you were to look in the crowns and bridges section, instead of paying the UCR, you'd be paying that lesser member rate. So it benefits you because even though, yes, you're still paying a big chunk out of pocket, you get a discounted rate if you go to an in-network provider. Some insurances require this, where you have to go to an in-network provider where you cannot pick and choose your providers. And there's some insurances where the premium is so little, so you're not paying a ton. Your options are very limited. Your coverage is very limited. And I've even seen some where they tell you what dentist you have to go to. So this gives you a good understanding of treatment plans and where the numbers are coming from, so you can better explain them to your patients.
In the Open Dental software, there is a section specifically for your treatment plan. When it's added in the chart section, which is the icon with the tooth, you'll see a visual representation of treatment that's already been completed, what needs to be done, the progress notes, all those things are there. But the treatment plan section is going to break it down in the financial side of things. You can create priorities and determine that these things should be done first, and then second, and then third. It'll tell us what teeth numbers and surfaces we're working with and the ADA codes associated with that. It'll also have the description and breaks it down for our patients. The first column is our office fee. What do we charge for that? The allowed amount is a negotiated amount. If you're an in-network provider, this is going to drop that amount down. Then we have our primary insurance, and we're estimating. I always emphasize that when I speak, that this is your insurance estimate, because I don't want to guarantee or promise something and then the insurance company not follow through with that, and then I look like I was being the one that was dishonest. So I say, this is what I estimate your insurance to pay. If they have secondary insurance, it'll calculate it in there too. If it's an in-network provider, it will have a discount section, and then the patient portion is calculated on the far right. You can see the columns on the bottom right that have the annual maximum and deductible in there. It keeps track of how much is being used, at least in our office. This would have to be manually updated if they went, say, to an oral surgeon or a endodontist. They all still pull from the exact same maximum we are.
At the top, you can save the treatment plan and then print it off, go over it with the patient, have them sign it. That way, you can scan it into their chart and you have proof that you went over it. So if they were to not follow through with treatment and something big arises because they didn't, they can't come back after the practice. If you perform treatment and they decide that you never told them how much it was going to cost, you can pull this document up and show to them that they were made aware of it and they agreed to the terms. It's also really helpful too, as the patient, to have something to go back to and refer to if we didn't schedule the day of and we wanted to go home and think about the financial side of it, because there are things in dentistry that are really expensive and a patient's just not able to commit to treatment right off the bat. They need to go home and figure out how, or if this is something that they can take care of financially. There is a card that they can sign up for. It's called Care Credit. Care Credit is a credit card that is specifically designed to be used in the medical setting, so it's not something they can go on a shopping spree with. That money can only be used at a medical or dental office. When you're notating on a clinical record, like you see here, blue typically indicates completed treatment by our provider. The red indicates treatment that needs to be done. Sometimes you are also notating watches on patients where it seems like demineralization has begun, but the tooth is not severe enough to warrant a filling. Let's take a moment. You can pause the video if you want, and I want you to take a look at this clinical record here and see what has been completed on this treatment. You can jot it down. All right, let's go through this together. Tooth number 1, what does tooth number 1, 16, 17, and 32 have had completed? This is a surgical extraction that has been completed on these teeth. Number 3. Number 3 and number 15 have both had sealants completed by our provider. Number 6. Now, number 6 is not treatment that's completed. This one is actually treatment that is planned. This is the incisal facial lingual filling. So you'll notice it's on the incisal edge of both the facial and lingual surfaces, indicating it's all one solid restoration. If I were to say incisal facial and a separate lingual, you might see a dot on the lingual surface where it might be indicating that it's a completely separate filling. It's not connected. It's going to require a separate prepared area of the tooth. Number 11. Number 11 needs a class 5 lingual restoration. Number 13. Number 13 needs an occlusal filling. What about number 14? What has 14 had completed? That's going to be your simple extraction, the simple line. And lastly, 19 as an occlusal filling completed. Pull out those handy clinical charts you've got because we're going to do some practice.
So we're going to go ahead and chart something pretty common where all 4 wisdom teeth have surgical extraction. It will depend on your computerized system and then ultimately your office too, whether they utilize this exact same icon as to a surgical extraction. Ours is a circle. The entire tooth is being removed, so we circle the entire tooth. Number 2, let's do an MO. An occlusal surface is the flat chewing surface of a posterior tooth, whereas mesial is the interproximal surface closer to the midline. 3, that needs a crown. We circled the only part that we're restoring. We're restoring this entire crown surface. So it's not all the little bits and pieces of a filling, it's the whole thing, but it's not like a surgical extraction where we're taking the whole tooth out. So make sure you only circle the crown here. 4, let's do a root canal, an RCT or endodontic treatment. And a lot of times following endodontic treatment is also a crown. Number 5, let's do a class 5 buccal. So first you pick the buccal surface, and remember that class 5 is right at the gum line. 6, let's do a mesial facial. We pick the facial surface, which is on the outside there, and instead of going right in the center, we go right to the side that's closer to the midline. 7, an incisal lingual, an IL, the incisal edge of the lingual surface. 8, let's do a distal lingual, the lingual surface, and then the side away from the midline. If we had to do a mesial lingual, like on number 9, we would mark the side closer to the midline, even though it looks just like number 8. Remember, the midline runs right down the center between 8 and 9, so that side of 9 is actually closer to the midline there. 10, let's do an distal facial. Number 10, a DF, distal side of the facial surface. We can do just a facial on number 11, so right in the center there. Number 13 is missing. We'll say that it had a simple extraction. So a simple extraction, a simple line through the entire tooth. And to create a bridge from 12 to 14, we would first have to prepare 12 for a crown. That's an abutment. We would prepare 14 for a crown. This is all in one setting. 3 different appointments here. That's also an abutment. And then the lab technician is going to fabricate the pontic, the missing tooth, which is number 13. So it's going to mark that it's going to get a crown, even though it's not cemented to number 13 because it doesn't exist anymore. It's attached to 12 and 14. This is a 3-unit bridge. There is no interproximal here. To floss, to clean up underneath it, they would need to use bridge threaders or an interdental floss aid of some sort. 15, let's go ahead and do a root canal in RCT. It's got 3 canals here. Let's go ahead and fill them all in. Let's do an occlusal filling. Maybe we kept it simple. Number 19, let's do a crown and a buildup. Now, a buildup is just how we communicate with insurance that we need to restore the tooth. It doesn't really matter if it's an MO or an MODBL, but that's how we're communicating with insurance that that tooth needed to be restored before it could get a crown. And BU is how we stand up. Create the stand-in for it. Number 21 is going to need an MOL, mesial, occlusal, lingual. Lingual is on the inside, so it's the inside picture there. 23 needs a root canal. And they need something called a post and core. It's a prefabricated structure that gives stability to this tooth to then later get a crown. Now the crown itself probably didn't have a lot of tooth structure, to prep. We couldn't actually create a prepared tooth. So the post and core prefabricates that. It's similar idea to a retention pen that gives strength and stability to a filling. This gives strength and stability and something for the crown then to hold on to. Let's do an incisal facial on 25, an IF 25, incisal facial. Let's do a class 5 lingual on 26, class 5 lingual. Gum line at the lingual surface. And a class 5 facial on 27. An OBL on 28. An occlusal, buccal, lingual. A DOL, a distal, occlusal, lingual. 30, a buccal. And 31, sealant. Those early on preventative measures we discussed about a thin plastic coating going down into the grooves of the tooth to help protect it against decay. This obviously doesn't cover every possible procedure that you can do in an office. So there's implants, there's dentures, there's all these different things. This gives you a great foundation to reading, interpreting a chart, not just in paper, but also in the computerized form also. Just make sure that you're practicing this and reviewing your charting and that you are proficient in what you're looking at.
Specialized periodontal exams are necessary to help us diagnose periodontal disease and help to determine the proper treatment course. A periodontal exam includes gathering the patient's dental and medical history, x-rays, and an examination of the teeth and tissues that support and surround the tooth. That's your periodontal charting. The periodontal pocket occurs when the gingival sulcus becomes deeper than normal, 1 and 2 and 3 millimeters, where the probe is able to go down beneath the free gingiva and next to the tooth surface is considered healthy. When we start seeing those 4s, that's where there's some inflammation, some gingivitis that as long as our patient does a better job of flossing, it should resolve on its own. But then we start getting those 5 and above, and that's a lot more alarming because the gums are receding. The bone that is intended to support that tooth is now also being resorbed and can result in a loose tooth. The purpose of the probing is to measure how much of the supporting tissue has been lost to disease. Rule of thumb, greater the pockets, the more severe the disease. When periodontal pockets are present, they're nearly impossible for the patient to clean on their own. And if left untreated, the disease will only progress until that tooth is ultimately lost. There may be some early signs of periodontal disease, including gingival changes, inflammation, bleeding, and even a foul smell or taste coming from the gums. Periodontal disease is the leading cause of tooth loss in adults and has been directly linked to early term births, low birth weights, and has a strong correlation with Alzheimer's. There's also research that supports that if somebody has periodontal disease, it actually puts them at a higher risk for more severe reactions when infected with things such as COVID-19 and pneumonia. What that really boils down to is that your gum health actually directly affects your whole body health. What the hygienist does is they take their periodontal probe and probes around each side of the tooth. There are 6 measurements on every tooth, and as they go through and they call them out, you're writing or typing it in the patient's chart. You're going through in the 3 measurements. There are 3 on the buccal or facial and 3 on the lingual, and they're sliding that probe around each time that they're taking those measurements. Usually we're taking these more on our adults unless there's an indication that there's an issue with, like, say, a teenager. But I see a lot of offices that start about age 21 probing and recording these on the yearly. If diagnosed with periodontal disease, your hygienist at your general dentist may step in and do what we call an SRP, a scaling and root planing, where they will scale the calculus off of the upmost portion of the tooth, and then they will plane, so they'll take their instruments and their ultrasonic scalers up underneath the gums and clean off those roots to hopefully help with the removal of necrotic tissue so that the tooth surrounding structures can heal. Some non-surgical periodontal treatment would include the scaling and root planing, the SRP, gingival curettage, cleaning with antimicrobial and antibiotic agents like your Arestin. That's a direct application of it. You can have locally. delivered ones where you're going to have the patient ingest them. And if this doesn't solve the issue, then we look into more surgical options, and that's where we're going to send them out to the periodontist to be seen more often on what we call a perio maintenance. They might be on an every 3 or 4 month cleaning interval instead of the average patient that's on an every 6 month interval, because we want to stay ahead of this disease, making sure that it doesn't progress.
Welcome to Entering Patient Payments with Open Dental. This is just going to be a short video to show you where you can set up basic preferences for your account module and show you how to enter patient payments. There is information on our website as well if you need additional help. Let's go ahead and get started. The first thing that we want to do before entering any payments is just set up our account module preferences. So to do that, we go to Setup, the very top menu, and down to Account. And we're not going to focus on absolutely everything that you see in this window. We're really mainly just going to be focusing on the lower right here where it says Enforce Valid Pay Splits. So Open Dental can be set up to do the work of attaching payments directly to procedures for you, make it really simple. Under that Enforce Valid Pay Splits, you've got 3 options. When we click the drop down, Don't Enforce. That option will just allow you to enter payments to providers rather than procedures. Enforce Fully. Payments entered this way will automatically attach to procedures. You can remove the recommended splits that it gives and manually choose your own. Any manual splits you do enter will have to be attached to procedures. Thirdly, there's the auto split only. Like the Enforce Fully option, the system will recommend splits, and you can have the option of removing those if you wish. Manual splits that you attach, they can be attached to procedures directly, or if you don't want to attach to procedures using that option, you can attach the splits just to a provider. We recommend the auto split. Just let the system do the work for you. Next one down, we have the auto split payments preferring, and there's 2 options, adjustments and FIFO. FIFO just stands for first in, first out, meaning that Open Dental will automatically suggest pay splits allocated to the oldest completed procedure on the family's outstanding charges. The adjustments option, similarly, if you use adjustments in your system, positive adjustments, if you ever increase someone's balance for failing an appointment or a return check fee, you can choose that adjustments option, and that'll automatically suggest pay splits allocated to the oldest positive adjustment on the account, and then it will follow the FIFO logic for the remaining charges. I'm going to leave it as adjustments. There's also a little checkbox there, hide pay splits from the payment window by default. I'm going to leave that checked. I'll show you what that looks like in just a moment. So I've got my preferences set here for what I want, auto split only and adjustments. I'm just clicking OK to save those preferences. And let's go ahead and enter some payments now. We're looking at the Baxter family. We can see on the right-hand side, Kevin has a balance, Yolanda has a balance, Emmett has a balance. I'm going to go ahead and first enter a payment for Kevin. So on the upper left is our payment button. We'll just single click that payment button. We'll be prompted to enter an amount. I'm going to say maybe they're paying $300 today. There is a little box you can check, prefer this patient, if you want the splits to first attach to charges for this patient directly rather than just choosing the oldest charge on the account. So I'm going to check that box and I'm going to click OK. I can choose the type of payment if it was cash, if it was a credit card. And if I want to see how that money is allocated on the account, there is a little button there on the left that says Show Splits with the drop-down arrow. I'm just going to click there. So I can see $242 was attached directly to Kevin, and the remaining $58 went to Yolanda since she was the next oldest balance on the account. That looks good to me. I'm just going to click OK. If I had wanted to, I could delete those splits and attach that money to someone else in the family, but that's the way I want it, so I'm just going to OK to save it. Let's go ahead and enter one more. I'm going to choose Emmett. Emmett has $95 balance from a visit last week. I'm just going to click my payment button. And let's say they are paying $95. I want it to prefer Emmett, even though that's a newer balance from just last week. I'm going to check the box. I'm going to click OK. And again, if I want to see how that money was allocated, I can click the drop down. Everything was attached to Emmett's last visit, totaling $95. I'm just going to OK to accept it. And it's as simple as that. Open Dental did all the work for me. If you need any other assistance, there's a very good detailed explanation on our website on the manual page there. And we hope that this was helpful.
Proper medical updates are necessary at each visit. This doesn't mean that they have to fill out a full new form, but simply getting into the routine of when you put your bib on them, that you ask them, has there been any changes in your medical history? Are you still taking these medications to help prevent a preventable medical emergency? Taking those vital signs, looking at the medication list, and then notating them. This is all about risk management and proper documentation. Putting anything and everything that you did in wording into your documents. The medical history alerts the dentist to these possible conditions and then medications that can interfere with dental treatment and helps aid in anticipating potential medical emergencies. Their chart may have an associated medical alert like allergies and other important health conditions, and a lot of scheduling software has what we call a pop-up, where when you click on the patient's name, it actually pops up in front of you and you have to exit out of it to continue any kind of things that we want us to have drawn to our attention. Or there may be red lettering to help draw your attention to such conditions in the patient's record. Looking over the dental history, we are not only asking their full medical history about allergies, past medical complications, or any conditions that we want to know about, but we will also ask them their dental history. Do they have any sensitivity to their teeth? Have they ever had oral surgery? When was the last time they've been seen by the dentist? What are their opinions around the dentist? Are they anxious? Do they like going to the dentist? Are they happy with their smile, or would they rather have a straighter, wider smile? All of this documentation helps us to better serve our patients and be a better practitioner. Assuming that we've done really good detailed documentation, we've updated our medical history, preventable things can be prevented. But there are those situations that we just can't help. It's probably no surprise that you may have patients that become a little anxious coming into the dental chair, and they may exhibit signs and symptoms of potentially fainting, like pale skin, lightheadedness, and even saying that they feel like they're going to pass out. To help prevent them from passing out, you're going to want to make sure that their head is lower than their feet. If they're in the dental chair, we can actually recline it completely in that subsupine position. If there's in our reception area, have them sit down slowly, maybe lay down on the floor, apply cold compresses, oxygen masks, get them cooled down if possible. If they do pass out, if they're in the chair, just place them in that subsupine position. Or if they fell on the ground, lift their legs up, prop them up. And if you have it available, you can use those smelling salts that you break underneath their nose to kind of bring them to. Since we are working in a patient's mouth, there is the potential risk of a patient choking on a crown if it got knocked loose, a piece of tooth, anything that we have inside of the mouth. Being prepared with your suction right there so that that doesn't happen is really important, but also understanding how to help in that situation is going to make you feel more confident should it arise.
Can I help
After
you?
confirming that the person is choking and obtaining consent, give a combination of 5 back blows and 5 abdominal thrusts. First, position yourself to the side and slightly behind the person. Bend the person at the waist so that his upper body is as parallel to the ground as possible. Firmly strike the person between the shoulder blades with the heel of your hand. Give 5 back blows. After the 5th back blow, reposition yourself to stand with one foot in front of the other, placing your front foot in between the person's feet to provide balance and stability. Find his navel with 2 fingers from one hand. With your other hand, make a fist and place the thumb side against the person's stomach, right above your fingers. Cover the fist with your other hand. Give 5 abdominal thrusts, pulling inward and upward. Continue giving sets of 5 back blows and 5 abdominal thrusts until the object is forced out and the person can cough forcefully, speak, or breathe. Or, if the person becomes unresponsive, send someone to call 911 if it has not already been done. Carefully lower the person to a firm, flat surface and immediately begin CPR, starting with compressions if you are trained. For a child, you might need to kneel in order to give effective back blows and abdominal thrusts. After confirming that the infant is choking and obtaining consent, give a combination of 5 back blows and 5 chest thrusts. First, place your forearm along the infant's back, cradling the back of her head with your hand. Place your other forearm along the infant's front, supporting her jaw with your thumb and fingers. Do not cover the infant's mouth. Turn the infant over and lower her onto your thigh so she is face down with her head lower than her chest. Give 5 back blows. Firmly strike the infant between the shoulder blades with the heel of your hand. Then, reposition the infant. Place one hand along the infant's back, cradling the back of the infant's head with your hand. Next, turn her over so she is face up with her head lower than her chest. Give 5 chest thrusts. Place 2 fingers in the center of the infant's chest, just below the nipple line. Press down about 1.5 inches, then let the chest return to its normal position. Continue giving sets of 5 back blows and 5 chest thrusts until the object is forced out and the infant can cough forcefully, cry, or breathe, or until she becomes unresponsive.
If a person should become unresponsive, then we want to make sure that we carefully lower the person to the floor and begin the steps of CPR. What is going to be a little bit different is that between our breaths, we should check to see, after we've done our compressions, before we do our breaths, to see if that object has been pushed up, and then we can grab it and remove it. Do not just blindly stick your finger down in there and do a finger sweep, as you may actually push that object further down. You'll notice if it's a complete obstruction as you try to give that breath, it's not going to go in. Their cheeks are going to puff out. You'll notice the resistance. If some of the air goes in, that's great because it's going around the object, and a little bit of oxygen is better than none. Respiratory issues and heart issues are some of the major medical emergencies that we kind of try to anticipate when we're going throughout our daily life. Cardiac-related medical emergencies like atrial fibrillation, supraventricular tachycardia, and heart attacks are all potential heart-related issues. If you notice that someone's having signs of any of these with a fast heartbeat, tightness in the chest, difficulty breathing, pain radiating, 911 is the best route. We're not trying to diagnose and figure out, is it because of atrial fibrillation? Is it because of supraventricular tachycardia? Like, those things are going to be detectable through an EKG. What we're noticing is that there is actually an emergency occurring. The difference between the atrial fibrillation and the supraventricular tachycardia is that AFib has a fast regular heartbeat, whereas SVT has a fast irregular heartbeat. Whereas the heart attack is slightly different. This is actually caused by a block of blood flow to the heart muscle, causing that tightness. And women tend to have less obvious symptoms. It's not like this agonizing, tight pain on the left side of the body. It tends to be a lot less obvious, to where sometimes they even brush it off as no big deal. Now, if you should suspect that there's an emergency, and then we're stepping in to help in that scenario. That's when we're going to call 911. But before you ever go into a potential emergency situation, you've got to make sure that that scene is safe. If you're already in the scene, it's happening real time, obviously that's, past. But if you were to see something happen or see someone unconscious, take a quick glance around. Make sure there's no obvious signs of danger for yourself. Downed electrical lines, fires, hanging hazards, potential for you to be injured yourself. Check for responsiveness by tapping their shoulder and shouting, hey, are you okay? That tactile and auditory input should cause someone to stir if they were conscious. But just because they're unconscious doesn't mean that they actually need to have CPR. So you're going to check for the pulse and respiration, call 911, have someone grab your first aid kit and AED, and start the step of CPR should you need that. We're going to briefly introduce these skills, but in our clinicals is when we're actually going to apply and delve deeper into them.
Hey, are you okay?
After confirming that someone is unresponsive and not breathing or only gasping, assume cardiac arrest and begin CPR.
He's unresponsive. Go
Ensure the person is on his back on a firm, flat surface such as the ground. Next, kneel beside him and place the heel of one hand in the center of his chest, with your other hand on top. Interlace your fingers and make sure they are up off the chest. Position your body so that your shoulders are directly over your hands. With this technique, you can use your body weight to help compress the chest. Now, give 30 chest compressions. Keeping your arms straight, push down at least 2 inches, then let the chest return to its normal position. Continue to push hard and fast, giving compressions at a rate of between 100 and 120 compressions per minute. For a child, push down about 2 inches, and for a smaller child, you may only need to perform chest compressions with one hand. Next, give 2 rescue breaths. First, place a breathing barrier over the person's nose and mouth. Then, open the airway by putting one hand on the forehead and 2 fingers on the bony part of the chin, and tilting the head back to a pass-neutral position. For a child, you'll only need to tilt the head to a slightly pass-neutral position. Pinch the nose shut, take a normal breath, and make a complete seal over the person's mouth with your mouth. Blow for about 1 second while looking to see that the chest rises. Take another breath, make a seal, and give a second rescue breath.
1 and 2 and 3 and 4.
Continue giving sets of 30 chest compressions and 2 rescue breaths until you notice an obvious sign of life. An AED is ready to use and no other trained responders are available. You have performed 5 sets of CPR and another trained responder is available to switch.
1 and 2 and 3 and 4 and 5 and 6.
You have performed 5 sets of CPR on a child. You are alone and need to call 911.
17, 18, 19, 20, 21, 22, 23, 24.
EMS personnel take over.
28, 29, 30.
You are alone and too tired to continue. Or the scene becomes unsafe.
1 and 2
Have
and
the
3
AED
and
and
4
first aid
and
kit.
5.
If an infant is unresponsive and not breathing or only gasping, assume cardiac arrest and begin CPR. Ensure the infant is on her back on a firm, flat surface such as the ground.
The baby's unresponsive.
Next,
Call 911
stand or
and
kneel
get
to
the
the side
AED
of the
and first aid
infant
kit.
and place 2 fingers on the breastbone just below the nipple line with your hand closest to the infant's feet. Now, give 30 chest compressions. Using the tips of your fingers, push down about 1.5 inches and then let the chest return to its normal position. Continue to push hard and fast, giving compressions at a rate of between 100 and 120 compressions per minute. After the 30th compression, prepare to give 2 rescue breaths. First, place a breathing barrier over the infant's nose and mouth. Then, open the airway by putting 1 hand on the forehead and 2 fingers on the bony part of the chin and tilting the head back to a neutral position. Make a complete seal over the infant's nose and mouth with your mouth. Blow for about 1 second while looking to see that the chest rises. Take another breath, make a seal, and give a second rescue breath. Continue giving sets of 30 chest compressions and 2 rescue breaths until you notice an obvious sign of life. An AED is ready to use and no other trained responders are available. You have performed 5 sets of CPR and another trained responder is available to switch. You have performed 5 sets of CPR, you are alone, and need to call 911. EMS personnel take over. You are alone and too tired to continue, or the scene becomes unsafe.
I have the AED in the first aid kit.
22, 23.
For someone in cardiac arrest, calling 911 or the designated emergency number, starting CPR immediately, and using an AED as soon as possible gives the person the best chance for survival. Cardiac arrest can occur when the electrical impulses that cause the heart to contract rhythmically become abnormal, disorganized, and chaotic. The heart will stop beating or beat too ineffectively to circulate blood to the brain and other vital organs. 2 abnormal heart rhythms in particular, ventricular fibrillation and ventricular tachycardia, can often be corrected by defibrillation, the electrical shock delivered by an AED. When effective, the shock disrupts the abnormal electrical activity long enough to allow the heart to spontaneously develop an effective rhythm on its own. An AED is simple to use. The device will guide you every step of the way. AEDs can be used on people of all ages and can also be used on pregnant women. All you need to do is turn the device on and follow the voice and visual prompts. Remember, start CPR immediately and use an AED as soon as possible. For each minute that CPR and AED use are delayed, the person's chance of survival is reduced by about 10%.
At the completion of this week's training video, you're going to have a brief understanding of how to handle a medical emergency, but you still must complete that in-person training course that includes the CPR and AED operation to be considered CPR certified. We are required as dental assistant radiographers to maintain a current CPR certification. And if you are already certified, you are still required to attend the clinicals this week because we are also completing other skills on that day. Emergencies are just that, emergencies, and they happen. And in some cases, they're preventable, and other times we have to think on our feet. We try to be as proactive when it comes to emergencies as possible so that if they do arise, we have protocols in place that make it less stressful. Each office is going to have an emergency action plan that's going to outline what we do in certain situations, including tornadoes, fire, medical emergencies. It may be outlined in a binder, and you're getting trained on that upon hire, or it's just going to be simply that they're verbally giving those training. And again, if they don't go over this upon hire, I'm going to be proactive and ask these questions. It is good practice that you have a printed version of your daily schedule within reach in case of an emergency. You can quick grab that and go, whether it's to your tornado safety space or exiting the office because of a fire. You can go through that schedule to try and account for everyone that should have been in the office at that time. In 2023, Ohio actually saw 60 tornadoes, while just a year before, in 2022, it only had 27. And that was a drop from 2021, which had 31. And in 2019, there were 49 tornadoes. And in the year 2015, we only saw 7 twisters in the state. While most of these struck cornfields and abandoned buildings, there really is a possibility that with us living here in the Midwest, there could be severe weather that occurs while we are at work. In our emergency action plans, it should detail where and when to go to your office's tornado sheltering area. Typically, it's going to be, and safest place is going to be in an interior room, away from windows, and if possible, in a basement if that has it in your office. After the risk of severe weather has passed, then the doctor can declare an all clear and everyone can exit the sheltering area. If possible, try not to permit staff and patients to leave amidst the actual severe weather. So if there's an active tornado going on, try to keep your patients from leaving. Now, that doesn't mean physically block them and hold them in. They are able to decide that for themselves, but maybe strongly encourage them to stay and then document that they didn't. But really, in these cases, the safest place is, again, that interior room or a basement if possible. Opposite of a tornado, in the case of a fire, you do not want to remain inside the building. You should never go back into the building for any reason whatsoever. Don't go back in to grab your personal items or anything like that. You want to have the emergency exit routes posted. Be aware of how you can get out of the office, whether there's windows you can get out of, doors to get out, where are the fire alarms, exit signs, extinguishers, where are those all located, and have they been inspected annually? That's something that legally we're supposed to be doing, but it is something that can be easily overlooked if we don't have a good protocol in place to make sure that they're getting examined. Once you are exited out of the building into the meeting spot that is established in your emergency protocol plan, then this is where you can take that printed off sheet that you have the schedule to account for all the patients and all the staff that were there that day. Once the fire department, medical emergency crews, police department have arrived, then they can tell you whether or not it's safe to re-enter a building, it's time to go home, whatever needs to happen next in that particular situation. If in the case there is a medical emergency, and we can sit here and name off a bunch of them, and when we get into our clinicals, we'll go over them again, but we want to notify our doctor of the medical emergency that's occurring. We want to immediately call 911 and begin CPR or first aid if it's needed in the situation. The good thing is if we're updating our medical history, we can quickly get in and gather their medical history to relay to the emergency medical personnel that's going to arrive on site. And if we can relay it through the phone, we can do that too. Taking vital signs will hopefully in some cases prevent this from occurring, but may also raise our attention to it happening. Now, there's always the question about HIPAA, privacy laws in the middle of an event like this. Normally, you couldn't just call a patient's family member and say, hey, they're here at the office. You're not going to just do that for no reason whatsoever. But in the case of a medical emergency, that is when you're going to reach out to their emergency contact that's listed to let them know what has happened. I don't generally give them the specifics of it because, again, I don't really even know all the specifics. I just say that there was a medical emergency that occurred in our office. Your loved one, XYZ, is being transported to this specific hospital, and then that's usually the extent of that conversation. Not releasing any of their, other protected information. They were here for an extraction, they were getting a filling done, and this happened. It is typically just this quick, your loved one's on their way to this hospital, and that, again, is the extent of the conversation. I hate the idea that we even have to talk about this, but it is a reality. It is a possibility, especially since some offices have nitrous on hand, and the nitrous oxide can be used in an improper manner for people to get a high. And so there are some times where dental offices have been broken into for that reason, for the small cash that they have on hand. Or even sometimes people think that because dental offices prescribe narcotics on the occasion, that they keep narcotics in their office. It is good practice to label that on the outside of your door, maybe save you some broken glass, that you guys don't keep narcotics on hand, that you don't, if your office doesn't use nitrous, that you don't have nitrous oxide on the premises, and that will hopefully deter someone breaking in. If someone breaks in after hours, then the alarm system's going to be triggered. The police are going to handle that. But let's say that you're in the office and there's an intruder, someone that's there, not for an appointment, they're being aggressive. You should have an emergency action plan in place for this. And usually it's just trying to de-escalate it. Don't try to make this person any angrier. Don't try to, work as the police here. What you want to do is stay calm, and if your office has one, press an emergency call button. It's a hidden button, sometimes underneath drawers, that you can push, and it will silently alert the alarm system and the police department in that area. If you can safely call 911, if you can, and then continue to remain calm throughout the situation. Next week is week 5, our midterm point. Wow, have we already made it here? That's awesome. Again, in this week's clinical, we're going to be discussing how the exam is formatted, and we'll have a chance to practice all the clinical skills that will be assessed. Go ahead and pull out your clinical chart because we're going to do a little bit of practice together again.